Good afternoon and welcome to my presentation on bile acid sequestrants, your partner on a journey to heart health. Your heart works hard. Squeeze a tennis ball. Your heart uses approximately the same force to push blood through the healthy vessels approximately 100,000 times a day. LDL, a certain type of cholesterol, deposits plaque on the walls of the arteries. Now the heart must squeeze even harder to move the blood through the body. HDL, the healthy type of cholesterol, removes plaque and makes the heart's work easier. Triglycerides also contribute to plaque buildup. Where does cholesterol come from? Some cholesterol comes into the body through your diet. It's important to realize that only food that comes from animals contains cholesterol. Avocados, nuts, and coconut oil are high in fat but have no cholesterol because they are of plant origin. Dietary cholesterol is absorbed from the digestive system into the bloodstream, where it can be used for both good and bad purposes. Bad purposes such as clogging your arteries, good purposes such as making bile acid salts. Not all cholesterol enters your body through your diet, however. Some cholesterol is made by your liver in order to make bile acids. The bile acids, which contain cholesterol, are stored in the gallbladder and released into your small intestine when you eat a meal that contains fat. Bile acids digest fatty meals. After their work is done, the cholesterol in the bile acids is recycled by the liver to be used again. As food passes from the mouth into the esophagus, stomach, and small intestine, it is digested into small units by enzymes. Bile salts break fat into small particles that enable enzymes to work more efficiently. After digestion, food is absorbed into the blood in the latter part of the small intestine. Waste and water then pass into the large intestine, where most of the water is reabsorbed into the blood. The wastes are stored in the rectum and then pass through the anus during the defecation process. The diagram shows how bile acids are dumped into the small bowel to assist with the digestion of fats. When they enter the colon, they are cycled back to the liver through the portal vein and reused to make the next batch of bile salts. Here are three different categories of cholesterol-lowering agents. The first ones are the statins, and they inhibit a certain enzyme that the liver uses to make cholesterol. The second category are the absorption inhibitors, such as Zetia, and they work in the cells of the small intestine to limit the amount of cholesterol that's absorbed. And then we have the bile acid sequestrants, which never actually enter the body. They just stay in your digestive tract and bind to your bile acids, preventing them from being reabsorbed, and used by the liver to make more bile salts for the next round of digestion. Let's learn more about the bile acid sequestrants. As long as the bile acid sequestrant is in your small intestine at the same time as the bile acids are released from the gallbladder, it will capture the bile acids and prevent the cholesterol from being recycled by the liver. The next time your liver needs cholesterol in order to make bile acids, it will be forced to remove LDL from your blood. As a result, your blood LDL will decrease, your endothelial plaque will decrease, and your heart will be healthier. Your partner, the bile acid sequestrant, will pass out of your body in your next bowel movement. There are three bile acid sequestrants currently available for use: cholestyramine, or Questron, and I believe it's probably named Questron because it sequesters the bile acids and prevents them from going back to the liver for recycling. Colesevelam and colestipol. Notice that the generic name of all of these drugs begins with the prefix chol. This is your clue that they help lower cholesterol. Cholestyramine must be mixed with water or another non-carbonated fluid. Colesevelam must be taken in tablet form. Colestipol is dispensed in granule or tablet form. The granule form must be mixed in carbonated liquid, and the tablets must not be cut, crushed, or chewed. Who needs bile acid sequestrants? Some people inherit a gene that causes their cholesterol metabolism to be altered. This condition is called familial hypercholesterolemia. Even if they eat a low cholesterol, low fat diet, they still have extremely high cholesterol levels. Bile acid sequestrants can help to lower LDL levels in these clients and prevent them from developing heart disease. Some people have high cholesterol levels due to a high fat diet. Bile acid sequestrants can help to lower LDL levels in these clients. Look at that high fat meal. Bile acid sequestrants will inhibit the absorption of other medications if they are consumed together. All medications must be taken either 1 hour before or 6 hours after the bile sequestrant is ingested. Since bile acid sequestrants are not absorbed into the bloodstream, they only have localized adverse effects on the GI system. Nausea, constipation, and bloating are common problems. Clients taking this medication should be on a bowel program to assist with evacuation. Because bile acid sequestrants decrease the absorption of fat-soluble vitamins and fats, they can potentially harm the fetus. Development of the fetal nervous system is particularly dependent upon the proper concentration of fats in the maternal blood supply. If the benefit to the mother exceeds the risk to the fetus, however, bile acid sequestrants are the drug of choice to lower maternal cholesterol, because the other categories of cholesterol-lowering drugs, such as the statins, have been proven to cause fetal abnormalities. African Americans suffer disproportionately more deaths from cardiovascular disease than white Americans, although they have normal or higher HDL levels and lower serum triglyceride levels than white Americans. Research performed by Healy et al. Suggests that African Americans may have a dysfunctional form of HDL that doesn't protect arteries from developing plaques as well as they do in white Americans. So if you look at these lipid profiles between white and black Americans, you can see that African Americans actually have healthier lipid panels, and I always assumed that they had less healthy lipid panels. So even though their lipid panel is healthier and they do have a lot of HDL, it's non-functional. That's what the theory is, and that's why they have higher incidence of heart disease and hypertension. There are alternative therapies to controlling cholesterol other than medications, and we can stop smoking. We can lower our cholesterol levels with medications, also with dietary changes and exercise. We can reduce our risk factors for hypertension. We can lose weight, and we can start exercising. So focusing on exercising, what are some specific benefits? And that would be that exercise increases your healthy cholesterol. It reduces your unhealthy cholesterol, it's in your blood, as well as your fats. It reduces obesity, improves endothelial function. That would mean improving the lining of your arteries. It reduces psychological stress, and we know that that can lead to hypertension. And it also helps you improve your fight to stop smoking. Interestingly, raw carrots in the diet actually cause blood cholesterol to drop. And we know that oatmeal works to lower cholesterol, and the reason why is it's fat soluble, and cholesterol is also fat. So fat dissolves fat well. So that's how oatmeal works to get cholesterol out of your blood. Soy protein lowers LDL levels by 3 to 5%. And then your plant sterols and stanols cause less cholesterol to be absorbed into the body they work in the same way that the bile acid sequestrant works. So what are sterols? They are similar in structure to cholesterol, but only found in plants. You can see they're found in fats and oils. That would be vegetable fat and oil, bread and cereals, fruits and vegetables, and nuts. My evidence-based practice, my research article found out that HDL exerts its protective effect on arteries not by cleaning LDL from arterial walls, but rather by preventing LDL from being oxidized with the help of an enzyme named paraoxidase 1. It has been demonstrated that African Americans have 50% less paraoxidase 1 than white Americans, plus higher levels of C-reactive protein and oxidized LDL. Dysfunctional HDL in African Americans could be causing atherosclerosis due to the buildup of oxidized LDL and unrepaired injuries in the linings of arteries. So this is the mechanism that they've actually discovered in terms of how HDL is working. It's not working by cleaning up the arteries like we previously thought, but it's actually working by preventing LDL from becoming oxidized, and oxidized LDL is what's causing heart disease. And then Zulig et al., this is my best practice article, used health belief model to find out what would cause clients to actually be serious about decreasing their cholesterol levels, since high cholesterol is an asymptomatic disease. So their research discovered that the only factor that is associated with patients' desire to improve cholesterol levels was the perception that hyperlipidemia is a very serious condition that could lead to heart and brain attacks. So we need to emphasize that hypercholesterolemia can lead to death and lifelong disability, and that is the motivating factor to help people cut down on their cholesterol in their diet. So in terms of nurse management assessment, we want to get a baseline of lipid profiles, weight, vital signs, bowel sounds, in order to determine how any adverse effects that the drug will be doing in the future for evaluation, as well as how are we improving all of this data. And then in terms of education, we want to find out what they know already so that we know where to start the education plan. And so we also want to know what they know about the medication already that they're taking, as well as, basically just to know what they know about the medication and how to lower cholesterol. In terms of implementation, education is the big one. We need to educate them how to take cholestyramine properly, and how to take their other medications properly, and the medications that they need for their bowel program if they do exhibit constipation. And we need to tell them that high cholesterol is a very serious problem that can cause death, and we need to monitor vital signs, weight, and lipid panels, and then encourage them to stop smoking. In evaluation, we are going to use the teach-back method to see how well they do understand how to take this drug. And then we are going to then reevaluate the lipid panel, the blood pressure, and vital signs, whether the patient is compliant with the medication, and whether they can describe adverse outcomes. And here are my references. And let me bring up my patient education brochure. And here it is, cholestyramine, its action, its side effects, oops, its benefits, how to take it properly, and when to call your doctor, and references for that. So thank you for watching.